Hello guys, welcome back to our channel. In this episode, we'll be looking into the second part of our lecture series on Physiology of Body Fluids. Just as rightly stated in our first part, in this part we'll be looking into the basic principles that surround osmosis and osmotic pressure. This is very important and essential for understanding of body fluids. Now let's go to our whiteboard and do some illustrations and relevant explanation. From your basic biology, you all know what osmosis is all about. Osmosis can be easily be understood. Let's say we have a water can like this. So this is still about basic biology. So in osmosis, there's a need for the presence of a selectively permeable membrane. Okay, and this selective permeable membrane can be likened to the cell membrane. The cell membrane, the endothelial cells, allows movement of water. Okay, it allows, especially the capillary endothelium, the fenestrations allow movement of water, but it doesn't allow movement of electrolyte, the ions, the cations and the anions. So that makes it a selectively permeable membrane. So just as the name implies, selectively permeable membrane. But then, in some situations, this electrolyte, the cations, the anions, they still need to move from the extracellular space, the extracellular fluid outside the cells into the cells. Okay? So this still happens. Or we say that from the plasma, intravascular space into the extravascular space. So there's a communication in the extracellular space themselves between the intracellular space and between the intravascular space and the extravascular space. And there's also communication between the intracellular space and generally the extracellular space. So this has to be understood. So now, as I've said, this is the capillary. Okay, these are the endothelial cells. Okay, all these things, all the spaces here are the fenestrations. Then this is the cell. Okay, let's say this is the cell, and this is capillary bringing blood to the cell. So in between the cell and the capillary, there is the interstitial space. Okay, and communication exists. Fluid exchange, excuse me, fluid exchange exists between the intracellular compartment and this is intracellular compartment and the extracellular compartment. Okay, while the endothelial cells and cell membrane allows movement of water, because in the cell membrane there are ungated and gated channels that allows movement of water, and also in the endothelium the fenestrations also allow movement of water. Okay, so communication exists between intracellular fluid and extracellular fluid. Communication exists. I think that's gotten right. Yeah, that makes sense. But then this communication or this exchange has to be well regulated. If not, there will be fluid imbalance. So as I've said, water passes intracellular fluid, extracellular fluid, sometimes unidirectional and sometimes bidirectional. Okay, depending on the need for fluid balance. So meaning that what the fluid in the extracellular space and intracellular space, there has to be isotonic to each other. Isotonic. So isotonic. While the one in the extracellular space also has to be isotonic. So from the word iso, the same, they have to be of the same tonicity. And this will lead us to talk during the course of this lecture. We need to talk on the osmolarity and osmolality. Of course, difference do exist between them. Osmolarity and osmolality, different exist. And that will also lead us to talk on the type of fluid that exist, which are the hypotonic fluid, hypertonic fluid, and the isotonic fluid. So in any instances when there is kind of imbalance, let's say the fluid in the extracellular space, the intravascular fluid, the plasma is hypertonic, while that in the intracellular fluid is isotonic. This is an imbalance. Do you guess what the outcome will be? Are you saying the right thing? So the outcome will be that the hypertonic fluid has more solutes, okay? The hypertonic fluid. So let's come back to our cylindrical can. So let's say this is hypertonic fluid. Hypertonic fluid has more solutes, okay? And the more the solute, the lesser the water concentration. The more the solute, the lesser the water concentration. These are the solutes, and all these solutes, they are the electrolyte, the sodium chloride, and that constitute the bulk of the electrolyte. As I've said, that sodium and chloride constitute about 80% of the electrolyte contribution of the plasma. So any value you are not getting for the molarity of sodium chloride will serve as the molarity of the extracellular fluid. So let's do some little calculation. So sodium Na plus and chloride minus. Now for you to get the osmolarity, you need to use a physiologic fluid. And a typical example of physiologic fluid is 0.9% sodium chloride. Let's get to the next page. 0.9% of sodium chloride is a typical example of a physiologic fluid. Now, the interpretation of 0.9% sodium chloride is simple. It's just as you saying that 0.9 gram 0.9 gram in I've made a mistake. 0.9 gram 0.9 gram in sorry about that. 0.9 gram in 100 milliliter of solution of sodium chloride. This is the meaning. Or in a more practical way, we can still say 9 gram in 1 liter of solution. So meaning that what 9 gram per liter. 9 gram per liter. That is the meaning. Now for you to now calculate your osmolarity, you need to know the molecular weight of sodium chloride. And the molecular weight of sodium chloride is about 58.5 or 44 thereabout. So it's about 58.5 or 58.4 thereabout. So the next step now is for you to then divide 9 gram per liter divided by the molecular weight. Okay, 58.5. You are going to be getting value around 0.154 osmol. 0.154 osmol. So that is the value you are going to be getting around that value, 0.154 mole per liter. Okay, 0.154 mole per liter. So now, just as I've said earlier in physiology, the way you do your liter, milliliter, you just have to know conversion. If you want to convert this to millimole, which is the SI unit that is one of the standard SI units that's acceptable. So you can accurately say this is about 154 millimole per liter. 154 millimole per liter. Okay. So let's open another page and see how further we can go with our calculation. Sorry about that. I have to make some adjustments so that we have enough feed to work. So let's continue. This should also be cleared. So I said what we are getting for our molarity is about 0.154 mole per liter. And I said this has to be converted to millimole per liter, and that gives us 154 millimole per liter. But this is in terms of mole. You know that one mole is equals to, when you want to convert this to osmoles, okay, you have to convert this to osmole. So, and one mole, in converting this to osmoles, one mole is about, could be one osmole, and one osmole is about the Avogadro's constant from your chemistry. So that's why all this basic stuff are still something that is that you may need to apply as time goes on. One osmole is about the Avogadro's constant 6.02 multiplied by 10 raised to the power of 23, if I may be right. 23. So the basic interpretation of this is that for 1 mole of sodium chloride is about 2 osmole. We give you about 2 osmole, okay? Because of what? It contains 2 ions, sodium and what? Chloride. For, let's say, substance that has 3 ions, 3 dissociable ions, 3 ions that can be dissociated separately. Let's say, for instance, sodium sulfide, Na2, sodium sulfide, SO4. So 1 molar substance of Na2SO4, it contains sodium, it contains sulfur and oxygen. It will be 3 osmole. Okay, so now for you to now calculate your precise osmolarity, you have to multiply 154 multiplied by 2, because sodium chloride is your 2 osmole. So by 2, when you now multiply 154 multiplied by 2, you are going to get something around 308. So 308 osmole per liter. However, this is already in millimole, so it will be 308 milliosmole per liter, while the molarity is about 154 millimole per liter. But because osmole is the number of osmotically active substances in a osmotically active solute, okay, in that substance, which and the osmotically active solute that we have here, there are 2. Hence, that's the reason why we are getting this 308 milliosmole per liter. And as I've told you that sodium and chloride makes up about 80% of the extracellular fluid in the plasma. So meaning that what? The osmolarity of the blood or of the plasma is around this value of 300, 308 thereabout, is around this value. And you also get the same values obtainable for the interstitial fluid, and the same values obtainable for intracellular fluid, because I said that they have to be isotonic to each other. The moment tonicity is increasing in one compartment than the other, you should know what will happen. That's where the principle of osmosis will come to play. Because by the time solute or osmolarity is increasing, meaning that the solute substance increase in that compartment and the water concentration decreases. That's just the meaning. The moment there's hypertonicity, solute is increasing. When solute increases, water concentration decreases. That is why you are going to define osmolarity as the movement of water across a selectively permeable membrane from a medium or from a region or from a compartment of higher water concentration to a compartment of lower water concentration. Or you can simply say, in terms of you defining it based on solute, is the movement of water from across a selective permeable membrane from area of lower solute concentration, or when there's lower solute, there's higher water concentration, like that. From an area of lower solute concentration to an area of higher solute concentration or lower water concentration. So that's how it is. So this value of 300 or 308 milliosmole per liter is the normal osmolarity of the body, And that's why the physiologic fluid that you give patient in the hospital, so this is kind of advanced, but then you still need to know. Like this normal saline. Normal saline has sodium and chloride and is 0.9%. So it has osmolarity around this value of 300, 308. But sometimes we want to do some correction factor due to interionic force. So when you want to do correction factor due to interionic force, you might want to multiply by 0.93, and that is just the 0.93 is more like 0.93 is more like the correction factor due to the interionic forces between sodium and chloride. So at the end of the day, you will still be getting 286 milli osmo per liter. So anyhow it is, 286, 300, and this value is the isotonicity, and that's why 0.9% sodium chloride is what is isotonic fluid physiologic. But by the time you are now talking of hypotonic fluid, let's say 0.45% of 0.45 normal saline, so of sodium chloride, 0.45 sodium chloride, for example, the value you'll be getting will be around 260 or 270 if you do the calculation based on what I've done. So it means that 0.45 gram of sodium chloride in every 100 milliliter of the fluid, or 4.5 gram in 1 liter of the fluid. So your calculation will now be that the molecular mass of sodium chloride is 58.5. Okay, so you are going to divide 4.45 divided by 58.4. So whatever you get, you will get around 0.1 to clinical one. I don't want to do the calculation. It's something you can also do. So in short, you will get a osmolarity that is lower to 280. So in that case, that is hypotonic. And when you are giving a patient hypotonic fluid, that fluid is entering into the plasma. That is a compartment, extracellular fluid compartment. So, and we said that the osmolarity in the intracellular fluid is also around 300 or thereabout, 28 clinical 28 something to 300 thereabout. So that there's rather an imbalance, and as such, there will be movement of fluid from area of what? Area of lower solute concentration or higher water concentration to area of lower solute to an area of higher solute or lower water concentration. So you are given a hypotonic fluid. That fluid is in the plasma, in the capillary, in the extracellular fluid space. So, and in that very case, there will be movement of water from the capillary space down to the cells. And in that very case, the cell will swell, and that could cause edema. Or in some other case, that is cellular edema. In some other case, the fluid will move into the interstitial fluid. Because I said that interstitial fluid also, the osmolarity also around the 300, 280 to 300 thereabout, 290 to 300 thereabout. So when the fluid moves to the interstitial, that's edema, typically edema. Okay, and that's why in our clinical vignette, I said when a patient that comes with increased intracranial pressure, in that very scenario, it means the patient has cerebral edema. Okay, and in patient with cellular edema, of course, the brain is a cell. I'm just using that as an example. The brain is a cell. So, and there's a cellular swelling, there's brain swelling as a result of that injury. Okay, so that is edema. And so the fluid that is contraindicated based on that vignette I painted in at the start of our tutorial and our very first video. So it means that we can't give hypotonic fluid because hypotonic fluid will will cause more fluid to enter into the cell. But by the time you give hypertonic fluid has higher solute and lower water concentration. And for the definition of osmosis, osmosis is movement from higher water concentration to area of lower water concentration. Hypertonic fluid has lower water concentration and higher solute. So mean that what? The fluid will be drawn from the cell down to the what? Down to the extracellular space, which is the intravascular space, which is the plasma. That's why I said the movement of the fluid is bidirectional based on the what? Based on the osmolarity. So now there's a need for us to also learn about osmotic pressure. Okay, in osmotic pressure, there's a pressure that is responsible for, you know, pushing out the fluid from the capillary into the interstitial space, okay? Into the interstitial space. So you won't get tired of this drawing. So it's something you have to know. These are capillary and this is the cell. This is the cell. So there's a pressure responsible for movement of fluid outside, movement of fluid from the capillary to the interstitial space, and that pressure is known as hydrostatic pressure. So when you get to your cardiovascular physiology, this will be discussed more in a more broad way. Hydrostatic pressure. Okay, hydrostatic pressure. Hydrostatic pressure is the pressure that is responsible for, for pushing out fluid into the outside the into the interstitial space. So there's also another counteractive pressure. A counteractive pressure, a pressure that counteracts hydrostatic pressure, and that is the pressure that is responsible for bringing in water into the intravascular space. And that pressure is majorly, or the bulk of that pressure is determined by the protein concentration in the blood, by the proteins and the solute concentration in the blood. So they tends to draw in water into the intravascular space, and that pressure is known as colloid oncotic pressure. Colloid oncotic pressure, colloid oncotic pressure. So anyhow you pronounce it, oncotic pressure. So proteins are in the what? We have enough proteins in the intravascular space, and that proteins, they are so essential in maintaining the intravascular fluid volume by drawing in water from the interstitial space into the intravascular volume. Okay, so they serve as an osmotic pool of water. So in hydrostatic pressure, act in the opposite direction by pushing out fluid from the intravascular space into the interstitial space. So this is another homeostasis now. There has to be balance between the colloid oncotic pressure and hydrostatic oncotic pressure. By the time the hydrostatic pressure is more by the time the hydrostatic pressure is more prominent than the colloid oncotic pressure, guess what will happen? I hope you are making the right guess. Okay, what's your guess? Okay, are you saying there will be more water outflow into the interstitial space? If that's what you are saying, you are very correct. So in the other extreme, when the colloid oncotic pressure is more than the hydrostatic pressure, do you know what will happen? That's why I say this thing is bidirectional. So there'll be more inflow of water into the intravascular fluid, and that's exactly what we want to happen. So there has to be an effective arterial blood volume. Okay, effective arterial blood volume, because the fluid in the interstitial space is not really useful, and it will accumulate to some point to cause edema, and that is principle of edema. Now let's go back to our slide and see what we can discuss. So the definition of osmosis has been defined repeatedly. Is the movement of water molecules across a selectively permeable membrane. This selective permeable membrane is very essential in your definition. It's very essential. Although if in our subsequent lecture, when we want to discuss about cell transport in physiology, or transport in physiology, active and passive transport, osmosis is just an example of passive transport because of what? Osmosis is not using any energy gradient. Okay, it's not using any energy or ATP. So it's an example of passive transport. So when we get there, we might not be able to, because of what we have said on osmosis now, we are not be able to give more elaborate explanation on osmosis. But then the other types like diffusion and facilitated diffusion, they should be discussed in greater details. But for now, since we are discussing osmosis, I think you have to note it very well. Osmosis is more what I call a selective permeable membrane. Mean that what it is selective to water, but it is not selective to solute, which are the electrolytes and proteins. Get it right. So movement of water across a selectively permeable membrane from a region of higher water concentration or lower solute concentration, as I've said earlier, to a region of lower water concentration or higher solute concentration. As I've said, the movement is bidirectional. based on the pressure. Hydrostatic pressure being low, water moves. Hydrostatic pressure being low and osmotic being high, water moves from the interstitial space to the intravascular space. Hydrostatic pressure being higher than colloid oncotic pressure, water moves from the intravascular space into interstitial space. All right. So that has been said, and I said that there has to be some equal level of osmolarity, which is the number of solutes in the solution on both sides. That's why I said that the value should be around 300 milliosmol based on the calculation I did. We need to get this 300 milliosmol in the intravascular, the same 300 milliosmol or 1 or 2 or less. I think it is 1 milliosmol lesser in the interstitial, but that's not significant to cause imbalance. And the same thing should be obtainable the same value should be obtainable in the intracellular 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 space fluid. So by the time there's kind of significant reduction or increase in any of these, then there will be an imbalance and water will move from one compartment to the other. So I think this explanation is clear enough. So here are a practical example. So adding solute like salt water decreases the concentration of water. As I've said, the more the solute, the lesser the water concentration. All right. And also the lesser the solute, the more the water concentration. The more the solute, the lesser the water concentration. That's why when you are defining osmosis, you must not define osmosis based on water concentration only. You have to factor in the number of solute as well, because anywhere there is more solutes they serve as they increase the colloid oncotic pressure and pull in water with them. So direction of movement, as I've said, from low solute concentration to high solute concentration. Membrane permeability. So cell membrane allows certain molecules like water, they allow water to pass through gated and non-gated channels. So all these things will be discussed further under cell transport in the subsequent videos by God's grace. So there's ungated channel. So the ungated channel are those channels they are not regulated. That's why they are ungated. So water can pass through the pores, the aquaporins. So yeah. However, the other channels that allow solute to pass, these channels, they are gated. They could be voltage gated. They will be ligand gated based on the position of the cell membrane in the body. Okay. So this one allows solute to pass. Okay, if there's enough energy like the sodium potassium ATPase, so it allows sodium potassium ATPase allows sodium to pass from the intracellular fluid to the extracellular fluid. Okay, because if the sodium potassium ATPase become faulted, like in a case when I said sodium potassium ATPase requires ATP to function. So in a case when there's reduced ATP as a result of reduced blood flow, when there's reduced blood flow, there'll be reduced oxygen. And when there's no oxygen, there won't be cellular respiration. Glucose will not be able to produce ATP in the absence of oxygen. So that channel won't see any ATP, and it will become faulted. So it won't work. So in that very case, the sodium remains inside inside the cell. I know that the osmolarity will now increase from 300 in the intracellular fluid, will increase from 300 to to just anything depending on the number of the sodium, and sodium is a solute, so it contributes to the colloid pressure. So in that very case, the osmotic pull will occur and sodium will pull in water into the cell. The cell will become swollen, and that is cellular edema. So that, of course, is something clinically is a serious issue. Now, osmotic equilibrium. So osmotic equilibrium is maintained when there's isotonicity. So the intracellular fluid is about 300 milliosmol, interstitial is also about 300, and extracellular, which is intravascular, is also about 300 milliosmol based on the calculation we did. So that is a kind of equilibrium. So there won't be any net movement of our water. The only thing that will cause net movement of water in this situation is the hydrostatic pressure, which is dependent on the pumping activity of the heart. Okay, which is dependent on the plasma volume. So when there's enough hydrostatic pressure, so that causes fluid to leak into the interstitial fluid, and from there into the intracellular fluid. Because of course this is also useful because nutrient has to pass and other substance in blood has to pass from the capillary into the tissue for cellular function. So osmotic equilibrium is crucial for cell survival, preventing cells from shrinking or swelling excessively. I've explained how cell will swell excessively, but for shrinking is when there is lower osmotic concentration in the blood, in the plasma. For shrinking is when there is higher osmotic concentration in the plasma. Maybe you are giving a patient hypertonic fluid. Excuse me. Hypertonic fluid in the sense that we said 0.9% is of sodium chloride is a physiologic fluid. Maybe a patient is now receiving 5% dextrose saline. Dextrose is glucose. Glucose itself is osmotically active substance, and it contributes about 272 milliosmol per liter. In addition to the already 300 milliosmol per liter of sodium chloride, you are giving dextrose saline, 5% dextrose saline. Dextrose is about 270 gram, 270 milliosmol per liter, and your sodium chloride is already 300 or 286 about milliosmol per liter. By the time you now add them together, you're getting something like 500. So 500 is already higher than the 300 that is in the interstitial fluid, and also the 300 around the 300 that is approximately 300 that is also in the intracellular space. So meaning that one compartment is now having higher solute concentration than the other. So osmosis will occur in what direction? Osmosis will occur from the what? From the area of lower solute in the what? In the interstitial and the intracellular space into the what? Into the intravascular space, and the cell will shrink. Okay, the cell will shrink because the cell is losing water, it's losing fluid. The cell, as you have said, as you said that the cell is either made up of about 60% of water, so it will shrink. So, and that is crenation. So we call it crenation. Okay, crenation. Now, moles and osmoles, I think I've explained this that 1 mole is equal to 1 osmole, but not in all cases. For solid that has dissociating, for substance that have dissociating solutes, let's say sodium chloride, so it will dissociate into sodium and chloride, so that will give you 2 osmole instead of 1 osmole. For glucose is just 1 mole of glucose, 1 osmole per liter. Okay. So, however, as I've said, 1 osmole and 1 mole they are equal, but not in all cases. They are different based on the what in a substance that has dissociating solute. Okay. And I also said that this 1 mole can also be equals to 6.02 multiplied by 10 to the power 23, solute particle, which is Avogadro's constant. Okay. Now, let's look into the principle of osmolality and osmolarity. So, the basic thing is that sometimes in laboratory measurement, they are being used interchangeably, synonymously. Okay. And sometimes they are used differently depending on the scenario. But then the difference lies majorly in the SI unit. Osmolality is just the osmoles per kilogram, while that is osmolality. Okay, osmoles, the osmotically active particles per kilogram of water. But okay, I said kilogram of water, you'll be somehow confused that is water a mass? Like, is it really a solid mass? Why is it being represented in kilogram? So that's where the fault lies in osmolality. The way water is being represented in kilogram, that's where the fault lies. And that's why in clinical practice and some laboratory, they will go with osmolarity, which is what? The concentration of, is the definition of osmolarity, the concentration of osmotically active particles per liter of solution, because it is easy to represent your solution, your fluid in liter, compared to being represented in kilogram. Okay, and that's why it's been said here that is commonly the osmolarity, which is measurement of solute particles per liter, is commonly used in clinical and physiological context. As I've said earlier, it could be interchangeably used in some condition. So I said this earlier about the correction that in the calculation that I did, why I got about 300 or 309 milliosmol per liter for sodium chloride, and I said because of the interionic interaction that exists between sodium and chloride, there is a correction factor which is the osmotic coefficient, which is 0.93. So by the time you now multiply 0.93 with 3 you multiply 0.93 and 309 milliosmol per liter together, you are going to get a new value which will be lesser because of the interionic correction, which is about 286 milliosmol per liter. So this is more of chemistry. For the chemistry lovers, I'm sure you should be aware about the Van Hoff's law. So this is just what it talks about. Excuse me. Now, I've said this earlier that sodium and chloride makes up 80% of total osmolarity in plasma and interstitial fluid. And that's why the value that we get for sodium and chloride, which is about 286 to 300, is being used as a standard, as a standard. Because since it's the major contributor, so meaning that what if you are getting 286 as your, as the 80% of the constituent of that fluid. So meaning that the remaining 20% should if you sum it up should still be around 300 or thereabout. So that's why the osmolarity is about 300. What the osmolarity is strictly calculated from the number of solute. Okay, and I said to you that so since the cells need to be in balance, what we get from intravascular has to be in balance with the interstitial, has to be in balance with the intracellular to maintain isotonicity. If there's any imbalance, just know that the fluid will move in the direction of the imbalance. Okay? Now, I've also talked on isotonic, hypotonic, and hypertonic fluid, of which I made an example of a isotonic fluid is the 0.9% sodium chloride is the physiologic fluid. So there could also be lactated ringas lactate. There's also 5% dextrose water. But by the time you're talking of hypertonic fluid, like 5% dextrose saline. So this 5% dextrose water only contain glucose, which is about 286 or which is about 270 milliosmol per liter. So by the time you're now saying 5% dextrose saline or dextrose sodium chloride, meaning that what even the sodium chloride is about 300, you are now adding it to the dextrose again, which is 270. So that is about what 500. No, that is already hypertonic solution. For your hypotonic solution, as I explained earlier, is that the lesser percentage of this 0.9, like 0.45% sodium chloride. So by the time you do your calculation of 4.5 gram in 1 liter, you now divide 4.5 divided by the molecular weight of sodium chloride, which is about 58.4. You'll be getting a value that is less than 270, maybe 260 or thereabout, or 230 or 230. So that is what lesser osmolarity, that is hypotonic solution. And I told us that the hypotonic solution is clinically significant in the scenario that I painted with a patient that presented with traumatic brain injury following road traffic accident, and the patient comes in with sign of increased intracranial pressure like effortless vomiting, a patient that is vomiting effortlessly. So those are the signs of increased intracranial pressure, or a patient that presents Cushing's triad. Now, what is Cushing triad? Cushing triad like raised blood pressure, elevated blood pressure, low heart rate, bradycardia, and breathing difficulty, dyspnea. So a patient that presents with this triad, It's also pointing to raised intracranial pressure. Any patient that when you do your fundoscopy, you check the retina through fundoscope. When you do your fundoscopy, you are seeing papilledema. So that is also another sign of raised intracranial pressure. So you should know that, from your Momo-Kelly phenomenon, I don't want to go much deep. I don't still want to talk of Momo-Kelly phenomenon, but if you are interested in knowing Momo-Kelly phenomenon, no problem about that. So there's cerebral edema, okay? There's increase in the what? In the water content of the brain, cerebral edema. So in that very case, the osmolarity in the cell has increased. So what you are going to do now is that you are trying to use a fluid that will get water out of the cell. So I know that osmosis is movement from what? Area of what? Area of you know higher solute concentration or lower water concentration to an area of what? So we want to get movement of water from area of lower solute concentration, area of higher water concentration, area of lower solute concentration. What there's cerebral edema, so there's higher solute and there's lower water concentration. So what you are going to use is a hypotonic fluid, which is what? Lower solute and higher water concentration. Okay, water lower solute and higher water concentration, which is hypotonic fluid. So that fluid will help to what? Yeah. So sorry about that. I think I made a mistake. So in someone that has cerebral edema, there is higher solute and lower water. There's a higher solute and a lower water concentration. So in that very case, what you are going to use is hypertonic solution, because in hypertonic solution there is higher solute and lower water concentration, and that will help to what? Draw out fluid from the what? From the cell. This is how you do it. Just forget about if there is a cellular swelling. Anytime there's cellular swelling, just forget about the solute clinic and the cell. What you should be main concern, what should be your main concern should be the tonicity of the what? Of the fluid in the capillary that is going to that region of the body. So the fluid in the capillary has to be a fluid that has higher osmolarity and lower water concentration, so that it can be able to draw in fluid from the cell. Okay, so it has to be an hypertonic solution and not hypotonic solution. So an instance when you need hypotonic solution may be an instance when there's excessive when there's hypernatremia. Okay, there's more solute in the intravascular space. When there's more solute in the intravascular space, and classically that will be seen in patient that has excessive sodium, which could occur as a result of so many reasons. Excessive sodium could occur in a patient that has adrenal tumor. So you know that the adrenal gland is responsible for the secretion of mineralocorticoid. So don't worry, when we get to the endocrine physiology, so we'll be talking more. This is more of 300 level stuff. So we'll be talking more about endocrine stuff. Excuse me. We're talking about endocrine stuff. So when there's adrenal tumor, there's excessive aldosterone secretion, and that will act on the distal renal tubule, distal part of the kidney tubule, to cause more retention of sodium. So there'll be hypernatremia. Another instance that will cause hypernatremia is a patient that have symptoms of inappropriate ADH secretion. ADH actually helps to, no, you can't have in symptoms of SIDH. I think that's not a classical example. So a patient that has adrenal tumor can end up having hypernatremia, or patient that have ADH, yeah. Patient that has lack of response to ADH, antidiuretic hormone, because antidiuretic hormone is preventing diuresis, and you know that diuresis is loss of fluid from the body through the kidney. So when there's no diuresis, as a result of action of antidiuretic hormone helps to retain fluid. There are some instances when the receptors that are meant to work with ADH might not work in the renal tubule. Okay, when this receptor fail, that is known as the nephrogenic diabetic insipidus. There will be excessive secretion of fluid. And when there's excessive secretion of fluid, there will be concentration of solute. So it's more like you pouring sugar into, into a cup of water. So when you pour sugar into a cup of water, and there is normal balance between the water and the sugar, you feel it that, oh, this sugar has more effect. But by the time you are now, you now pour more water out of the cup. Let's say the water that remains in the cup is one fourth of the water of the initial water, and you now pour the same amount of sugar. You see that the concentration of the sugar will increase, so it will become more conk. So in that very case, if there is lesser fluid, if there's lesser fluid in the body as a result of, diuresis, loss of fluid through the kidney, okay, and such as in diabetic insipidus, the concentration of solute become more concentrated, and in that very case, there will be hypernatremia. Another instance may be in a patient that sweat a lot. When you sweat, you lose a lot of fluid, or in any other condition when there's a loss of fluid. So that could lead to hypernatremia. So in that very case, if you are giving your fluid, you are going to give hypotonic solution. Okay. So isotonic solution, we have discussed about it. So, and I said it's around 22 milliosmol per liter, and that of the sodium chloride, which is intravascular extracellular, is around 286. After doing your correction factor, what you got was 309 milliosmol per liter. But by the time you do your correction factor from Fant off formula, 0.93, when you multiply 309 by 0.93 with doing your correction factor, you are going to get 286 milliosmol per liter, which is the difference is not really significant. So we can still call them isotonic. So in each chamber, there is isotonic solution and there won't be imbalance. Okay. So we have cited so many examples. All these things are things we've talked about. So you can check them out. 0.9% sodium chloride is isotonic, 5% dextrose solution is isotonic. So the clinical importance, we have said the cell doesn't swell and it doesn't shrink. So a patient that comes in and the patient is sick and you don't see any need for you to, balance fluid in that patient, for you to, there's no any indication of osmolality, increased osmolality of intravascular fluid, which is the plasma, and also no any indication of cellular swelling. So in this very patient that are fine, or patient that needs medical condition, but they don't have any indication for them receiving hypertonic or hypotonic fluid. So just say that all things being equal, for a patient that present and want to give fluid intravenously, so you go with isotonic fluid, except in other cases like cellular edema. So in that very case, you are going to give hypertonic. Hypertonic will throw out fluid from the cell. Or a patient that has a hypernatremia, excessive solute in the intravascular fluid. So you don't want to give more solute again. So you give hypotonic fluid, okay? And while giving hypotonic fluid, you have to correct gradually. You don't just give it at once. So just have that basic principle at the back of your mind. Okay. So we have talked with the effect on cell, the effect on cells, which is for the hypotonic solution, the effect on cell is what it causes. Hypotonic solution actually, it goes into the cell because osmolality inside the cell is about 286, while for hypotonic solution will be about lesser than 250 or 200 thereabout. So what do you expect from your osmosis? So from area of what? Area of higher, area of lesser, water will move from area of lesser solute concentration to area of what? Higher solute concentration inside the cell. And there's higher solute concentration, it's relatively higher solute concentration inside the cell, which is about 300, and hypotonic is about 250 or even less than 200 milliosmol. So what do you expect? The cell will swell and it's good. The end result will be that the cell is going to burst. Okay, so those are the basic principles. I've been hammering on it, I've been repeating it. So you just have to know them, and you have to know them at spinal level, at your fingertip. So this stuff There are stuff that comes in handy, so you just have to know them. So this is hypertonic solution. We have talked so much about it. So hypertonic is just opposite to hypotonic. Hypertonic will throw out water from the cell, leading to shrinkage of the cell or crenation. So this is the crenation I'm talking about. Okay, the crenation, the crenation I'm talking about. As you can see, effect on cells. When cells are placed in a hypertonic solution, water moves out of the cells into the extracellular fluid, leading to cell shrinkage or crenation. So this is the clinical consideration, such as in the treatment of cerebral edema. And this actually, fall back to the vignette I painted at the start of our lecture in Physiology of Body Fluids Part 1. Okay, so that's why all this video you have to follow keenly with full attention. So someone that just decide to watch only someone that just decides to watch only part two without watching part one. So there are some things you have to be linking them together. So it's kind of the videos cannot be watched in isolation. So osmotic equilibrium. So I've said osmolarity difference across the intracellular fluid and extracellular fluid. They have to be what? They have to be the same or negligible. So if at all there's difference, if the difference has to be negligible, so that will ensure, that will ensure isotonicity, and it will ensure that there is no any massive movement of water in either direction. So all these things are things that I've said earlier. So now let's look more into some clinical application. So a patient that has diarrhea or a patient that is losing fluid. So you can either be losing fluid as a result of excessive vomiting. If a patient vomit a lot, maybe in the case of food poisoning, okay, staphylococcal food poisoning or even cholera. So in cholera, there will be diarrhea. So the anus literally turn to a tap. You just gushing out watery stool. Okay, just keep gushing out watery stool, and it could be as worse that the patient might end up losing as much as 20 liters of water in a day. And I said that, and I already said that the normal intake is about what? 3.2 liter. 3.2 liter, and that is already an imbalance. So in the case of severe fluid loss, that is dehydration. So that will also disrupt the osmotic balance, because you are losing water. As a patient is losing water, the concentration of solute is becoming more concentrated. Just as the example of water and sugar that I gave you earlier, that if you pour water in a cup and by the time you pour sugar in that cup that is filled with water. So by the time then after some time you take another quantity of the same quantity of sugar and the same quantity of water again. So you then pour out some of the water from the cup till 1/4 of the water remains in the cup, and you pour the same amount of sugar so that the sugar is more concentrated. Okay, and that is exactly a simple analogy of what happens when a patient loses fluid. It could be through the renal, as I've explained. When a patient has nephrogenic diabetes insipidus, it could be through the GI system, gastrointestinal tract, in the case of dehydration. So, and that, or through the GI tract, also through the vomiting. So there will be what? The fluid will become hypertonic. Okay, fluid becomes hypertonic. Okay, because the solute now will become more concentrated. So this note is a well outlined note. Of course, it could be used for exam, especially if you get to erythropoiesis and other aspects of physiology. So even in embryology, you're also going to, this is about basic medical sciences. Very soon there also be lectures on embryology, just histology, just name it. Okay, even biochemistry, enzymology, your pathways, what you need to know, and things like that. So hypertonic solution addition, this is the effect, this is what will happen. The effect is what? It increases extracellular fluid osmolality, causing water to move out of the cells. And that this points back to our first clinical vignette, where I was saying that if a patient is given hypertonic solution, then the options ECF increases, water comes out of the cell, ECF does this, ICF decreases, something like that. So you also need to know all these things. So by the time you are giving a patient hypertonic fluid, so the fluid is going to the extracellular fluid, which is intravascular fluid, the plasma. Of course, fluid level increases. Okay, fluid level increases. And because that hypertonic will cause more fluid movement from intracellular to the extracellular, the fluid level in the intracellular become decreased as a result of this movement. Okay, then osmolarity is increased in both compartments. So this is another trick. You have to listen so well. This is another trick. Osmolarity increases in both compartments after infusion of hypertonic fluid. Get it right. Because by the time fluid moves from intracellular space to the extracellular space, the fluid that moves from the intracellular space causes the solute in the intracellular space to also what? The solute and the proteins to also become more concentrated. And I said that the more the water concentration is coming out, the more the solute concentration. So the more the what? Osmolarity. And what determines osmolarity is the solute and the proteins. Any osmotically active substance, which could be electrolyte, the solute, the proteins. Okay, so in that very case, and because you have infused additional solute into the extracellular space from the hypertonic fluid you are infusing, there's additional solute there. So meaning that what? Osmolarity will also increase in the extracellular fluid. And as a result of the movement of fluid, causing more concentration of solute in the intracellular space, there will also increase in solute concentration. So in both directions, there's overall osmolarity increase in both compartments. Please, I'm really emphasizing on this part. You have to get it right. Don't get it confused. Because you might be like, since you give hypertonic saline at the solution, so osmolarity should only increase in the extracellular fluid. No, osmolarity will increase in both extracellular and intracellular, and I've explained the reason and the rationale behind it, which you have to take a very good note of. Okay, so yeah, you can look at all the examples here. Look at all the examples here and make more. You have to make more correlations with it. Okay. So these are just examples. So examples and the outcome. So effect of adding 2 liters of 3% sodium chloride. So 3% sodium chloride is that is hypertonic because it says 0.9% is what? Isotonic. Anything lesser than 0.9% is hypotonic and anything greater than 0.9% is hypertonic. So these are just basic calculations that you can do by yourself. So just try to wrap your head around it. So if you want to calculate the osmolarity of 3% sodium chloride, you say that 3% chloride is actually what? is 3 gram in 100 milliliter. So 3 gram in what? In 100 milliliter or 30 gram in 1 liter. So meaning that what? You will be dividing 30 divided by what? Divided by the molecular weight of sodium chloride, which is about 58.5. So whatever it is that you get will be you should get around 0.2 something. So you convert that to milliosmol, it will be 250 something. So by the time you now add, you convert it to millimole, it should be 200 and something. And I said that mole and osmole, they are different in a situation where there are two ions, two participating ion in a substance, and the two participating ion here is sodium and chloride. So meaning 1 molar of sodium chloride equal to 2 milliosmol. So you have to multiply that 200 by, around that 200 by 2, you will get around 400 and something. So I'm not sure of that calculation of that value, but that's just the steps. So and that is already more than 286 to 300, which is the around 286, which is the which is the isotonic. So that is hypertonic. So that's just a simple calculation. Okay. So now let's talk on electrolyte imbalance. Electrolyte imbalance, as I've said, the major contributor in the extracellular fluid is sodium and chloride. So and sodium contribute more to the what? More to the osmolarity. Okay, sodium is as more is a osmotically active solute. It helps to draw in water. So any imbalance in sodium is something that is very crucial for for osmosis and fluid balance in the body. So now that's why I need to know the normal value of sodium. So the normal value of sodium should be around 135 to 145 millimole per liter. That's the normal measurement. So anything higher than 145 is stamped, or anything higher than some text will say more than 150. Just know that all these things have clinical implications. Okay. Anything higher than 145 or anything higher than 150 according to some text is termed hypernatremia, while anything less than 135 is termed hyponatremia. Just as you are seeing on your screen, anything less than 135 is termed hyponatremia. So and there are causes of hyponatremia. Okay, so causes of hyponatremia, anything that can cause excretion of sodium from the kidney. So it will lead to what? Anything, just know that anything that can cause loss of sodium from the body will cause hyponatremia. So we have a whole lot of examples. So through the kidney, some diuretics causes loss of both water and also sodium. Get it right. So that will lead to hyponatremia. In the case of adrenal insufficiency, when there's inadequate secretion of aldosterone, and I told you that aldosterone is actually used to retain sodium in the body. So, but when the level of aldosterone is low, there will be less reabsorption of sodium in the distal renal tubules. Okay, less reabsorption of sodium and more sodium, and that will translate to more sodium excretion in the urine. So that also will be a cause of hyponatremia. So yeah, and also another cause of hyponatremia is dilutional hyponatremia. I've explained all this earlier. There is someone that drinks excessive amount of water. So I said the normal intake should be about 2 to 3 liters per day. But when someone drinks excessive, a significant increase or a significant, excessive amount of water, like 10 liter, 15 liter, that is going to dilute the solute in your body. So the more the water concentration, the lesser the solute. The more the solute, the lesser the water concentration. Basic mathematics. Basic. It's just basic. So a patient that ingests large amount of water, that overhydrates himself, or a patient that has been transfused intravenously with more water solution, what do you expect? The solute becomes diluted. So that is dilutional hyponatremia. So that is dilutional hyponatremia. Okay. Or another instance is antidiuretic hormone. I told us earlier that antidiuretic hormone is an hormone that is responsible for retaining water inside the body. This hormone acts in the distal tube of the kidney it helps to retain more water from urine. So you pass less urine and you retain more water. That's the function of antidiuretic hormone. So in a situation when we have a syndrome of inappropriate secretion of antidiuretic hormone, which could be due to a patient that has lung tumor of the lung, or a patient that has an intracranial infection, patient that have pulmonary disease, some will say pneumonia. So in this type of patient, they have excessive secretion of ADH. they secrete ADH from inappropriate site because the normal site for ADH secretion should be from the what? From the posterior pituitary. Okay, so by the time patient is now secreting ADH from ectopic site, you call it ectopic site, from the kidney, from the from the brain, and as a result of intracranial infection, meningitis, encephalitis, all these things lead to the inappropriate secretion of ADH. So and the end site, okay, the site where ADH is going to act still remains the same, which is what? Which is the kidney. So there will be more water retainment. And when there is excessive retention of water, what do you expect? The solids become diluted. So, and the bulk, the bulk percentage of solids we are talking about is also the sodium. You say sodium and chloride constitute about 80%. So sodium become diluted, and what happens? There is hyponatremia, and that is why in patient that has all these tumor, bronchogenic tumor of the lung, or patient that has intracranial infection, if you want to correct their fluid level, when they come and they are not able to take in any fluid, you still give them fluid, but the maintenance will now be two-thirds of the normal maintenance. You won't be giving them 3 liters per day. You will be giving them two-thirds of 3 liters per day because they are already retaining excess fluid. So that is the basis for you giving two-thirds of the what? Of the maintenance fluid in some certain cases, which I have mentioned just now. Now, consequences of hyponatremia. So, hyponatremia translates to what? Hypotonicity. Okay, hypotonicity. And you know that the consequence of this will be that what? The intracellular fluid is hypertonic, is relatively hypertonic compared to what? Hypotonic. So, what water draws in from the extracellular fluid to the intracellular fluid. So, it causes cell swelling. That's why in hyponatremia, the bulk of the symptoms a patient will experience will be neurological symptoms because the brain will start swelling. So an example of such is headache, nausea, lethargy, disorientation, and severe cases, seizures, coma, and the patient can die if there's no any intervention. So these actually are very, very important principles. So you know your symptoms of hyponatremia and symptoms of hypernatremia. You don't even need to disturb yourself. Just know this might be useful in a clinical phase. Just know the basic osmosis, principles of osmosis. So by the time you say okay, hyponatremia, the main thing is cell swelling, especially the brain. So that should ring a bell that okay, the symptoms that is pertaining to hyponatremia are the symptoms of what? Neurological symptoms of the brain, symptoms that are related to the brain. So by the time you are now seeing options that which of the following is not a symptoms of hyponatremia: A, headache; B, lethargy; C, disorientation, seizure as option D, and E they say muscle twitching, or option E they said muscle paralysis. So that should ring a bell that okay, the symptoms that is odd out of all these symptoms is muscle paralysis because it's not really related to neurological symptoms in the brain. Okay. And also, rapid correction of hyponatremia can cause osmotic demyelination. So that has also been explained. So osmotic demyelination, you don't correct it rapidly, and you don't correct it rapidly. So that will cause there is a term for it which is central pontine myelinolysis. Central pontine myelinolysis. So when there's a myelinolysis, so there's osmotic demyelination, and that will result in neuronal injury. So when you get to the action potential and resting memory potential, you understand, you will to appreciate why myelination is important in signal transmission. So when there's demyelination, signal conduction will be slow. There won't be sortatory conduction. Signal conduction will be slow, and that will translate to neuronal injury. So get it right. Now, hypernatremia, on the other hand, is when the plasma sodium concentration is higher than the normal, higher than 145 milliequivalent per liter, and there are also causes. So I've explained this earlier that diabetes insipidus. Where I was talking about nephrogenic diabetes insipidus. There's also crinogenic diabetes insipidus, which occurs when the posterior pituitary is not producing antidiuretic hormone, while the nephrogenic diabetic insipidus occurs as a result of lack of receptor. The kidney is not responding to ADH, okay, despite adequate ADH, but then the kidney is not responding to it. So there'll be free, you know, so in that very case, there will be diuresis. Diuresis is excretion of water through the kidney, while natriuresis is excretion of sodium through the kidney. So they are just basic terminology. So and also in any case where there's loss of fluid, so there's loss of intravascular fluid. So when there's loss of intravascular fluid, so that will cause decrease water concentration, and that will translate to increase solute concentration, and the bulk of the solute is sodium. So that is a hypernatremia. So in another instance where there could be loss of fluid is excessive sweating. So that is also something that should be noted. So hypernatremia also has causes. Other causes include in a situation where there's Cushing's disease. I've explained Cushing disease where I was saying adrenal. When there's a excessive, maybe there's adrenal tumor and there's excessive production of cortisol, because cortisol also has sodium retention property. Or in other cases, when there's aldosteronism, there's excessive secretion of aldosterone. That is Crohn's disease. Yeah, that is Crohn's disease. Crohn's disease, CONN. So there's excessive production of aldosteronism, which could be secondary to adrenal tumor. There's a tumor, and you know what aldosterone does? Aldosterone helps to retain sodium. So there will be increased the absorption of sodium in the kidney, the distal tubule of the kidney, leading to hypernatremia and fluid retention. So you all know the consequences of hypernatremia. That has been explained. When there's hypernatremia, the hypertonicity is increasing. So hypertonicity has increased. Basic principle of osmosis, there will be movement of fluid from area of what? Area of lower solute concentration to area of higher solute concentration. And there's higher solute concentration in the intravascular space. So by definition, there will be movement of water from the intracellular space to the what intravascular or the what extracellular space, and that will lead to shrinkage of the cell. Okay. So and also while I was explaining homeostasis in the first part of this tutorial, I told us that when there's hypernatremia, as part of homeostatic response, or as part of homeostatic mechanism in the body, as pertains to fluid regulation in the body, so that will translate to hypernatremia will translate to hypertonicity, and we have osmoreceptors in the hypothalamus. So osmoreceptors in the hypothalamus detect any changes in the osmolarity of the body fluid, and the consequence of that is that when there's excessive osmolarity, that will be picked up by the hypothalamus, and hypothalamus will trigger the thirst center of our body, of the brain, the thirst center of the brain. And of course, the next thing you see that you are doing is what? You are drinking more water. So as you drink more water, you are trying to dilute, the water concentration of the body starts increasing. So you are diluting the solute. And when water concentration increasing, the solute starts dropping. The solute concentration starts dropping till the what equilibrium is reached. Okay. So that makes sense actually. That makes sense. So when there's hypernatremia, all this has been explained. So you might not need to know the treatment. Okay, but For those in the higher classes, so a patient that has hyponatremia, you should know that when you are correcting this type of fluid, as I've said earlier, you don't correct rapidly because of what? Demyelination, known as what? Central pontine central pontine myelinolysis. Okay, you don't correct rapidly. And when you are correcting hyponatremia, you know that you are correcting with what? Hypertonic fluid, hypertonic saline. For hypernatremia, you should know that you are correcting with what? Hypotonic fluid. So that's just opposite hypo. When there's hyper, you correct with hypo. When there's hypo, you correct with hyper basic. Now, another clinical application here is edema, intracellular edema. So, like in cerebral edema, we talked about is an example of what? Intracellular edema. And a major cause of that is when there's hypotonicity in the intravascular space. So, fluid moves from the intravascular to the what? Intra, cellular, from the when as I keep saying intravascular, it also means extracellular. So the reason for me saying intravascular is that I'm being more specific with what? Plasma volume. I was not taking into consideration the interstitial, but synonymously extracellular. Okay, when there's a lesser fluid or lesser quantity of fluid in the extracellular, like hyponatremia, the movement of fluid from area of lower solute to area of higher, from area of yeah, from hyponatremia, from area of lower solute to area of what? Higher solute, and that will cause cellular swelling, and that will result into intracellular, intracellular edema. So, and also another way which imbalance could occur could be as a result of when there's reduced blood flow, the ATP system is not working, and when the ATP system is not working, there will be sodium accumulation within the cell. So you know that this ATP is actually responsible for driving out sodium from the cell into the extracellular fluid, into the extracellular space, from the extracellular space to the extracellular space. What is responsible is the active gated channel, which is sodium potassium ATPase through active transport. But whenever there is, this makes use of ATP. So I know that in producing your ATP, you need your oxygen. And how do you get oxygen? You get oxygen from hemoglobin inside red blood cell. Okay. So in a case when there is no hemoglobin, there is no red blood cell, and there is no blood. And what could be a major cause of this is when there is reduced blood flow, when there's a reduced blood flow to a particular organ. So in that organ, the sodium potassium ATPase won't work. And in that very case, sodium will not be able to be exported out of the cell. And when there's now sodium buildup in cells, what do you expect? There's what? Hypertonicity intracellularly. And that is going to cause movement of fluid from area of what? Lower solute concentration to area of higher solute concentration. So the cell becomes swollen. And when the cell becomes swollen, so that is what? Cellular swelling, that's intracellular edema. So there could be extracellular edema. So you know that extracellular fluid is subdivided into intravascular and extravascular. Then we have the intracellular space as a separate entity. So I've drawn this diagram over and over again, so I won't bother myself drawing or going to the whiteboard again. So as I'm saying it by mouth or without any illustration, I believe you should be having a mental picture of what I mean. You should start having that mental picture. So fluid can actually accumulate inside the cell, giving rise to intracellular edema. In the same vein, fluid can also accumulate in the interstitial space or interstitial component of extracellular fluid. I said the extracellular space is made up of both intravascular and extravascular or interstitial space. So it's three compartments. We have three compartments. Okay, intravascular is a compartment, extravascular or interstitial space is a compartment, intracellular is a compartment. When there is a fluid accumulation in intracellular, it goes by the name intracellular edema. When there is fluid accumulation in the second or the middle compartment, which is the extravascular or interstitial space, that is what extracellular edema. And that can occur as a result of what? Excessive leakage of fluid from the capillaries. So, and I said that the force that controls, you know, that controls or pulls fluid or pushes out fluid from the capillary is known as hydrostatic pressure. So when there's increased hydrostatic pressure, that of course is going to lead to interstitial edema. Okay? Or when there's lesser oncotic pressure, I say oncotic pressure is responsible for pulling fluid back into the intravascular space. So in any causes that can, cause low oncotic pressure, and it should be at the back of your mind that oncotic pressure uh, is being generated by proteins and the solutes inside the intravascular space, inside the blood vessels. And these proteins are the albumin, the immunoglobulins, the fibrinogen. So, and when you look at all these proteins, the major bulk of all these proteins is albumin. And you know that albumin is produced from the liver. The liver produces the albumin. So in any conditions that can result into low production of these proteins, that will translate to low blood colloid oncotic pressure, and that will lead to unopposed action of what? Hydrostatic pressure. So hydrostatic pressure is pushing out fluid, and the force that is responsible for pulling in fluid into the intravascular is lost. So there's unopposed action of what? Unopposed action of hydrostatic pressure. In that very case, that will lead to edema. Now, when you want to talk on causes of edema, you have to start based on what? Based on the physiology. You already know the physiology. You know where the hydrostatic pressure is coming from, which I said from the pumping activity of the heart and the fluid volume in the what? In the blood vessels. That's where the hydrostatic pressure is coming from. And you know where the oncotic pressure is coming from? It's coming from the proteins that are in the what? In the blood. So you can either have extracellular edema when there's excessive hydrostatic pressure that is pushing out fluid, or you can have extracellular edema when there is lesser oncotic pressure that is what? Pulling in fluid. So for when you now want to list extracellular edema, starting from lesser oncotic pressure that is pulling in fluid when there's no protein, which could be as a result of liver disease. So people that have liver disease like liver cirrhosis, liver cancer, just think of those are liver diseases, chronic liver disease. So that very patient are prone to having edema. Patients that are losing protein through their gastrointestinal tract, known as a protein losing enteropathy. So in protein losing enteropathy, this type of patient also they are predisposed to extracellular edema. Note it. And also patients just wrap your head around so many things. Patients that are losing protein from the kidney, patient that have a chronic kidney disease. In chronic kidney disease, the glomerular membrane becomes leaky, so it leaks. So the glomerulus is more like tufts of capillaries. So that's just glomerulus. So when we get to for 300 students, when we get to you know uh urogenital system, physiology and anatomy, you will appreciate all these things better. So the tuft of capillaries become damaged in chronic kidney disease. So in that very case, proteins become leaky. So proteins are leaked. So like in nephrotic syndrome, so there will be proteinuria. The meaning of proteinuria is proteins inside the urine. So when these proteins become leaky or when they are leaking, these are the proteins that are meant to contribute to the oncotic pressure, and these proteins are no longer there. So there will be unopposed action of what? Hydrostatic pressure. So that could also lead to edema. And that's why you see in patients with chronic kidney disease, they have leg swelling. Their leg will become swelling. So that's just the basic pathology there. So you see all these things still falls back to your physiology. That's why knowing your basic is so essential and it sets the tone for your practice. Okay, and of course, you still need to pass your exams. So, passing exams, so that one comes with another orientation on its own. Okay, so of which our academies are ready to help. Okay, you have past questions that you can use. Also, you have group of scholars that are ready to give you the right orientations and the right things to read when exam becomes fast approaching. So let's continue. Now let's talk on the hydrostatic pressure. Anything that will increase hydrostatic pressure, and I said that that comes from the heart, okay, or and the blood volume. So in a case when there's a heart failure, a patient that is not pumping enough blood outside, there will be backup of flow. Okay, when there's backup of flow from the left ventricle down to the left atrium down to the pulmonary system. So in the pulmonary space, so there will be pulmonary edema because of what? There's increased fluids in the what? In the pulmonary venous system. So there will be pulmonary edema. The capillary extracorporeal pressure increases because of what? The heart, there's no forward pumping of the heart. And in that very case, there's backflow of fluid. So from there, after some time, this is a gradual process. After some time, now we move from the what? From the pulmonary venous system, it gets into the right ventricle, from the right ventricle to the right atrium, from there to the vena cava system, which could be superior vena cava, inferior vena cava. So when you get to your cardiovascular system, anatomy, physiology, you appreciate this better. I'm sure those in 300 level, they know what I'm saying quite well. So there's excessive fluid backup after some time from the kidney, from the pulmonary system down to the right ventricle, to the right atrium, from there to the vena cava system. And that's why you see in heart failure patients, they also have body swelling. Their leg becomes swollen, their face becomes swollen. So these are that's just the simple that's just the basic causes or basic etiology of that swelling, which is extracellular edema that you see in patients with chronic kidney disease. I've explained the reason why. Chronic liver disease, which they are not producing enough protein. I've explained the reason why they have swelling. And uh chronic uh chronic heart failure, congestive heart failure, or congestive cardiac failure, CCF. I explained the reason why. Okay, so that's just the basic stuff there. So, and also let's talk of the lymphatic issue. In the first part of our tutorial video, I also explained the role of lymphatic system, where I said that lymphatic helps to return fluid and protein from the interstitial back to the intravascular. Now, there are some things that can cause obstruction of the lymphatic vessels, okay? The efferent and the afferent, lymphatic vessels, there are things that can cause obstruction. So, let's say in a case when the lymphatic vessels are being removed, lymph nodes and lymphatic vessels, when they are being removed as a result of cancer, for a patient that has breast cancer, some of these cancer can spread to the axillary group of lymph nodes, and as a result, the surgeon might decide to remove some of these axillary lymph nodes. And then as such, you know that axillary lymph node drains, it's actually perform that role of draining interstitial fluid of the upper limb into the intravascular volume around the upper limb area. So when the axillary lymph nodes are not there again, what do you expect? That patient present with hand swelling. That's why a patient that just undergoes surgery for breast cancer, I say mastectomy, removal of the breast, and that patient presents with hand swelling. So you should know that likely the surgeons have gone ahead to remove the axillary lymph node. That's why the hand becomes swollen. Although after some time it subsides. Okay. So there are also some other things that can block the lymphatic drainage. This time around, there's no removal of lymphatic drainage, but there's what blockage, such as in the case of parasitic infection, some parasites can thrive or they are being harbored in the lymphatic vessels, such as a filariasis. So if you can check online for a picture of elephantiasis, just search elephantiasis. You can check online. So you will see that the lymphatic vessels in the legs they are blocked. So the leg become as big as an elephant leg. So if you look at an elephant, so and the patient having elephantiasis, you see that the leg is as big as anything, And that in men, that can also lead to, hydrogen, the scrotum, there will also be fluid accumulation in the scrotum. So all these things are a result of what? Lymphatic blockage or removal of what? Lymphatic vessels. Okay, now according to extracellular edema, these are things that I've explained. So I'm not going back to them again. Chronic kidney failure, I've told us the reason why. High venous pressure, heart failure, I've told us the reason why. Okay, and also the veins, backup of blood flow in the veins, which could be due to heart failure and also be due to loss of venous pump. You know that from your cardiovascular anatomy, veins are being supported by valves. Okay, veins are being supported by valves. In a situation when the valves are not working, valvular insufficiency of the veins, that can also lead to backup of fluid, and that will cause a localized edema, not a generalized edema. It will cause a localized edema around that region where there's what? Where there's a loss of venous valves. Okay, so all these things have been explained. So another cause of edema is as a result of, from your cardiovascular physiology once again, there's a sympathetic tone that maintain arteriolar vasoconstriction. Okay, so in a case when there is loss of this sympathetic tone as a result of maybe damage to the spinal cord, or as a result of you know other disease of the spinal or other disease of the nervous system. So when there's loss of sympathetic tone, the vessels become dilated, and that can actually cause a fluid leakage. So decreased plasma protein, we have explained. Nephrotic syndrome, loss of protein in the urine, that has been explained. And also another instance where protein can be lost is when a patient, in a born patient, so a born patient loses fluids, loses protein. You know that I told us that insensible water loss is from the what? Respiratory tract and the skin. And they both contribute about 1.7 liter of fluid loss per day. However, this can be increased, especially from the skin in a patient with burn. So, and I told us that the conified layer of the skin, you have the stratum, the corneum, stratum granulosum, stratum, uh, spinosum, and stratum basal or basalis. Okay, so when there's a loss of conified layer, the conified layer actually serves as, it helps to preserve the water content, the capillary, the cutaneous capillary, cutaneous circulation. It doesn't allow the capillary to be exposed to the exterior. But then in a patient with burn, this conified layer is lost and the capillary are exposed. So there's not only loss of fluid, but also there's loss of proteins as well. So when there's much loss of proteins, of course, you should know that the colloid oncotic pressure become decreased. And I've told us in a failure, in a situation where there's failure to produce proteins, that could as well you know, lead to loss of reducing colloid osmotic pressure. So, like in liver disease, or in some instances, when a patient is not, or an individual is not eating enough food, is not eating enough protein, like in PEM or PCM, protein calorie malnutrition. So in PCM, protein calorie malnutrition, such as kwashiorkor, marasmic kwashiorkor, marasmus, just name it. So in this kind of instances, those children are malnourished. They are not eating protein. And this can occur in people that eat only carbohydrate without protein. So when there's no protein, the protein that you are eating is the one that is being used to synthesize the protein that you need in your body. Are you getting it? So when you are not ingesting enough protein, so an example of proteinous food, milk, egg, fish, chicken, dairy products, okay, beans also has little quantity of protein, but overall beans has more carbohydrates than protein. Some of you will always think that carbohydrate, beans is majorly a protein diet, but you are getting it wrong. Okay, beans is both carbohydrate food and has some lesser quantity of protein. The protein level is even lesser compared to the carbohydrate. So in a patient that is not eating enough protein, that means there won't be substrate. The protein you are eating is the one that is providing substrate for the production of the protein that you need in your body. So when these protein are not there won't be any substrate and there won't be any protein. And in that very case, that's why you see the kwashiorkor children, they have body swelling, their body will swell. You notice that big stomach, you know, their stomach will be big and there will be swelling. So, and that forms the basis of that swelling. They don't have protein and their colloid osmotic pressure drops. What will happen? There will be unopposed action of hydrostatic pressure and there will be fluid in the interstitial space. And that corresponds to what? That corresponds with extracellular edema. So there are so other many causes of increased capillary permeability. So blockage or lymph return, all this has been explained. So now let's look at fluid in the potential space. So the potential space, so I told us that while I was explaining, I told us we have transcellular fluid. In our first part of our lecture, I said we have transcellular fluid. There's under extracellular fluid. I was telling us that fluid outside the cell, it could be intravascular, extravascular, and 1 or 2 liters of the total body water comes from the transcellular fluid. So the transcellular fluid are the fluid in the joints area, which are these in the synovial cavity. So that synovial fluid is a transcellular fluid. And also, let's go to our whiteboard. At least let's play with some things in our whiteboard. So let's assume this is the heart. So sorry about my diagram. Let's assume this is the heart. So this is the left atrium. This is the left ventricle. This is the right atrium. So all these things you should know it from your as like 108 in other level. This is the right ventricle. Okay. So it is essential that you know that the outer covering of the heart is what? Is the pericardium. And this pericardium are two. There's visceral pericardium and there's parietal pericardium. So the visceral pericardium from your viscera is strictly adhered to the what? Is strictly adhered to the wall. So the visceral pericardium is strictly adhered to the wall. So now in between the visceral pericardium and the parietal pericardium, there's a little space, a very little space that contains pericardial fluid. Okay, and this fluid is actually there to maintain, when the heart is pumping, the heart will increase in size and also to absorb shock around the heart. So yeah, this is a potential space. Okay, this is a potential space, and as such, since it is a space, fluid can get accumulated in that area. Same thing goes for the lungs. So your lungs this way, your two lungs this way. So in the lungs as well, there's what? Parietal pleura and there's visceral pleura. Visceral pleura is closely adhered to the lung, excuse me, while the parietal pleura is not well adhered to the lung. So between the visceral pleura and the parietal pleura, there's a space which contains the pleural fluid. So this as well is a potential space. Same thing goes for the abdomen. In the peritoneal cavity of the abdomen, when you get to your GI, anatomy and physiology of GI, you understand these things better. In the abdomen, also is being surrounded by what? The visceral peritoneum and the parietal peritoneum. So that as well is a potential space, and fluid can accumulate in those potential space. So fluid accumulation now is into three. We talk about fluid accumulation in the cellular swelling, which is intracellular edema. Fluid accumulation in the interstitial space, which is what? Extracellular edema. And fluid accumulation in potential space. So any fluid accumulation in the potential space, you won't really call it edema. You are going to call it effusion. Effusion, okay? So if it is the heart, that will be called pericardial effusion. In the lungs, it will be called pleural effusion, while in the abdomen, in the peritoneum, there's nothing like peritoneal effusion. There's nothing like that. So literally, it should be called peritoneal effusion, but then it is known as ascites. Okay, ascites. Let me write it well. Ascites. Okay, it is known as what? Ascites in the what? In the abdomen. So that's just what that is all about. Fluid accumulation in potential space. Okay. So that's just what all this slide is all about, effusion. So we have come to the end of this tutorial on physiology of body fluids. So subsequent tutorial should be on erythropoiesis, erythropoiesis and all that it constitutes, where we'll be talking on erythropoiesis. Erythropoiesis is a common question in exams. And though this physiology of body fluids is not really a common question, that's why I have to dwell much on it. It's just a stuff that you need to know before discussing about erythropoiesis. I had the intention of making videos on erythropoiesis first, but I just read that erythropoiesis is about the red blood cells. What about the fluid level, the plasma that suspend the red blood cells? The plasma serves as the liquid medium for the red blood cells. So we need to. That's why I felt the need that the plasma level and the fluid, the plasma should be discussed first together with other body fluids, just to provide, to lay a solid foundation for you. So all these things that we have discussed, although there are some that I've gone to discuss, so I've gone outside the syllabus or outside the box, but then it's still all for good, okay? Just for you to have a solid understanding, to set the tone for your, to set the tone for your clinical knowledge later on, because all these stuffs are still something that you'll be needing later in future. So medical stuff cannot be studied in isolation. So it's more of complement. Yeah, whatever you know now and what you are going to know later on in future is going to serve as a complementary to what you already know now. No any new stuff except what it's a kind of complementary, okay? You add to your already existing knowledge bank. So thank you all. Thank you for your attention, for staying with me up to the very end. So this is where we are going to end our lecture. Don't forget to subscribe to our channel, Emekis Academy. We have also dropped our uh, we also dropped the link for our brainstorming group. You can come there to ask any questions that you have. And I said that you can ask questions that are not even limited to the topic of context, to physiology of body fluids. You can ask questions in anatomy, physiology, just anything you feel like you don't understand. Feel free to ask your questions. We are there for you. In our team, we have scholars. The scholars are there for you to answer your questions, to guide you in your exams, to provide exam tips for you and orientation sessions for you, how you can tackle your exams, your steeplechase exams. Likely past questions are available for your past questions for your self-study. They are all available. So like past questions are, they are so essential for your study. So they are all available. I wish us well in our academic journey. So this is where we are going to stop. Thank you for your attention. See you next time. It's not bye bye, but see you again. Subscribe to our channel and you get notification of our new videos. Thank you and God bless.